Hello, and welcome to our program. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. And our program, Digital Slide Review and Sign Out, is part of the Digital Anatomic Pathology Academy, a joint venture with Digital Pathology Association and Path Presenter. It's truly a great platform and offers the opportunity to review a host of great digital slides that you can learn from and easily share with one another. Our case today comes from the realm of GI pathology, and we're looking into the pancreas. Our patient is a 42-year-old gentleman who has been suffering with some progressive jaundice and has been found to have a pancreatic mass on imaging. So I thought we'd just first review the clinical scenario. Jaundice, of course, painless jaundice usually implies some sort of biliary obstruction. And in a younger individual, less than 50, I usually don't think of carcinoma first. I usually start thinking about other possible causes, like pseudocysts or other varieties of pancreatic neoplasms, like solid pseudopapillary tumor, especially if they're even a little younger than this gentleman. Neuroendocrine tumors, of course, can create problems, but usually are not associated with jaundice in this setting. Serous neoplasms, of course, usually are indolent and don't grow and progress to obstruct the ducts. Pancreaticoblastoma usually is much younger patients. And then, of course, there's the incipient neoplasms, the in situ intraductal papillary neoplasias and related ductal carcinomas that can at times develop in younger individuals. I think we also have to be concerned about the possibility of obstructive jaundice due to stones. And sometimes those can be associated with edema that gives the impression of a mass and stranding that can be interpreted as possible neoplasia. And then finally, autoimmune pancreatitis or sclerosing pancreatitis can also produce a mass that can look very much like a neoplasm. So this gentleman, in some institutions, might come directly to resection, especially if the mass appeared to be confined and contained. In some settings, those will just go directly to resection, a Whipple procedure, with even no thought of a biopsy. But in a younger individual, probably should be biopsied. This case, however, is a little bit older in our files and came to resection. And as you can see, we have a mottled pattern of pancreatic parenchyma. We have several ducts that are open, some that are surrounded by some blue cells. We have some pink sclerosis type material, variable amounts of blue cells associated with this, but nothing that looks like a dominant mass type lesion displacing the pancreatic tissues. Now, I apologize, this slide is a little bit dirty, so when you review it, you'll want to take that into account. But as we come into higher magnification, we can see that indeed there has been a tremendous amount of atrophy of the pancreatic parenchyma. We have the residual ducts here, but virtually no acinar parenchyma remains. However, in its place, we have this sclerotic fibrous tissue and an admixture of quite a number of inflammatory cells, which include some eosinophils that you can see nicely here. I think you can appreciate that there are a number of plasma cells. Right here, for example, you can see several clustered plasma cells. And then we have variable numbers of other immune cells, mostly lymphocytes and dendritic type cells as well, possibly some of the larger nuclei in there. And as we go around this tissue, you see that that's pretty much the case everywhere, with variable amounts of this, fibrocollagenous tissue associated with this inflammatory infiltrate that is here, and it shows again the mixed character with plasma cells, eosinophils, lymphocytes in the background. So this is unfortunately a a nice example of autoimmune pancreatitis with dense sclerosis mimicking a mass and marked loss of pancreatic parenchyma with this intervening inflammatory infiltrate. Now, this type of lesion sometimes can be sampled cytologically. I don't have the slides from a cytologic sample, but it would be a great diagnosis to be able to consider or suggest in the right setting with a mass lesion and a relatively sparse cytologic sample. You may have relatively few or variable components of epithelial tissue, which can include acini and ductal cells. And some of these can be a little bit atypical because of the inflammatory process. And ideally, you should get some mixed inflammatory cell population, some plasma cells, lymphs, eosinophils, and so forth. This would be particularly true with type 1 type autoimmune pancreatitis, which is what we've just seen. And then if you've got type 2, then you may see a few more histiocytes, maybe some giant cells along with this as well. Autoimmune pancreatitis is not a common lesion. It usually is more in the adult range rather than pediatric range, but can occasionally present fairly early in life, and sometimes is even gradually onset type of lesion with insidious, subtle weight loss, loss of appetite, maybe a little bit of vague pain, and then progressive jaundice if it involves the biliary tree. The CT or MRI findings may show a mass lesion and may very, very closely mimic neoplasia. As we alluded to, there are two primary types. The one we looked at, type 1, is typically found to be IgG4 related. In other words, there's an increase of IgG4 plasma cells in these lesions, as we find in other areas with IgG4 disease. And we'll talk a little bit about this contrast. Additionally, IgG4 can be elevated in the serum in these patients. So sometimes serologic testing can be useful as well. And then there is a non-IgG4 type, which tends to be a little more duct-centric and have oftentimes a somewhat granulomatous character to the inflammatory process as well. Looking to compare these, the nomenclature is slightly different. Idiopathic duct-centric pancreatitis for type 2 versus sclerosing lymphoplasmacytic pancreatitis or IgG4-associated autoimmune pancreatitis. These tend to be a little bit older, whereas type 2 tends to be younger and may even present in children. Interestingly, we do have a male predominance. It's almost 3-to-1 with the IgG4 disease, but equal in type 2. Jaundice is fairly frequent, but symptoms of acute pancreatitis is uncommon with IgG4. The imaging can be fairly similar. IgG4 in the serum can be elevated. And if you do immunohistochemical staining on these samples, you should find an excess or an abundance of IgG4 positive plasma cells. And of course, IgG4 disease can involve other sites, salivary glands or retroperitoneum, the cholangiobiliary tree, and other sites as well. Whereas the type 2 disease has some association with inflammatory bowel disease. Both of these entities do respond to steroids, and hence the importance of discovering or at least considering this diagnosis preoperatively. And this is the key reason for this presentation today, is so that you become aware of this entity and can potentially think of that when the time comes. So our final sign-out diagnosis is autoimmune lymphoplasmacytic IgG4-related sclerosing pancreatitis. And I hope that will alert you to the possibility. I will point out that the digital slides from this presentation, as well as some additional digital slide case examples of sclerosing pancreatitis, are included in the information about this video, and the link in that description below. So take a look at that and check out those digital slides so that you become a little more adept at the spectrum of disease that can be seen in this disorder. Well, thank you so much for joining me for this presentation today. I hope it's been useful to you. And you know the drill. Hit that subscribe button, hit the like, so that others can find this video and similarly share in the understanding that you've gained from it. And if you have questions, comments, observations, please don't hesitate to reach out to me. I always welcome your comments and feedback, and really appreciate that also with regard to suggestions for future topics. I've tried to include some of those as we go along and as I encounter additional cases. So until next time, thanks so much for joining me.